First of all, I would like to thank Dr. Honawar and AIOS for giving me the opportunity to speak on strabismus evaluation. To begin with, we will establish the goals of examination, and there are majorly it can be divided into four, so that it makes it easier for us. First and foremost is to establish the presence and type of strabismus, whether there is any pseudo strabismus or any latent deviation, and whether it is iso, exo, horizontal, vertical deviation, whether there is any presence or of amblyopia or not, whether what is exactly the amount of deviation for management, and to assess the binocular sensory status. But before we talk about strabismus, I think this is very, very important when it comes to pediatric patients, and we will have some quick slides on visual acuity. I won't be taking it in detail, but I always think that this forms the basis of strabismus evaluation, and I always like to take a couple of slides on this. So in children, there are different ways and methods to measure visual acuity. We should be aware of what are the visual milestones when we are examining kids. By 4 to 8 weeks, the fixation is very well developed. And by 3 months, they start reaching out to interesting objects. Obviously, this is a normal developmental milestones of the kids. And by 6 months, they start having the stereopsis is there, and if we test it on VEP, they will have 6/6 vision. And by 12 months, they will start scribbling with crayons. By 5 years, stereopsis is very well developed. This is just a small slide that, very small newborn infants also can see and can imitate the expressions. This is just a small division of detection visual acuity, resolution visual acuity, and recognition visual acuity. So our Snellen's comes under recognition visual acuity, but then there are preferential forced looking tests, Catford drum, and OK and nystagmus drums. Another pillar or another very important aspect of before we go to talking about strabismus evaluation is cycloplegic retinoscopy. An accurate refraction is very, very important because this controls your strabismus evaluation. So accommodation has to be controlled before you start going towards motor evaluation of strabismus. Motor evaluation of strabismus would be broadly divided into measuring the amount of deviation. Before you measure it, you have to qualitatively tell whether it is iso, exo. You have to do a cover test. And I think cover test is not just the first step, but in fact, cover test takes care of almost everything. So cover test is an umbrella test under which you have cover test, cover uncover test, alternate cover test, prism cover test, and corneal reflection test. So the types of deviation can be what exactly the cover test will do. It will tell you whether it is iso or exo. So you do a cover test, and when you cover the eye, if the eye comes from out to in, it is exotropia, and if it comes from in to out, it is esotropia. Whether the deviation is manifest or it is latent, whether it is unilateral, whether the fixation is only, whether there is a master eye, and whether there is a unilateral strabismus. Cover test tells you about amount of deviation, fixation pattern, whether there is any presence or absence of latent nystagmus, whether there is concomitant deviation, which means that fixing right eye, fixing left eye, if there is any incommitance, whether there is any presence or absence of amblyopia, and if there is a dissociated deviation. That also cover test will tell you. What are the tools needed for cover test? You need a fixation target. Don't do it with a torchlight because you need a fix. As I said, you need to control accommodation. You need to know whether the child is accommodating or the person is accommodating a lot or not. So you need a fixation target, and you should control accommodation by giving adequate glass power, whatever their glass power is. So you have to do a cycloplegic retinoscopy before you start managing strabismus. You need an occluder. You can use palm of the hand, but not fingers, because light and target can be seen through it. Torchlight only for Hirschberg corneal reflex test, not really for cover test, and prisms to measure the amount of deviation. Corneal reflex test is like inspection, and so 1 millimeter of each millimeter of eccentricity would point to around an angle of 7 degrees. And if the reflex is at the pupil, you can say that it is around 15 to 20 degrees. So this is just a brief way of finding out whether it is ESO or exo. It may be pseudo strabismus in corneal reflection test. And so the gold standard comes back to cover test. The first part of cover test is cover test, which means that you have to cover the seemingly fixating eye, which means that when you feel that if it is the left eye which is fixing, you have to cover the fixating eye. Because if you cover the non-fixing eye, you don't get any information. You cover the seemingly fixating eye and see the response of non-fixating eye. If it comes from out to in, it is exotropia. If it comes from in to out, which means that if the eye is nasally placed and if it moves temporally, then it is esotropia. If it moves from down to up, it is hypo, and if it moves from up to down, it is hypertropia. Basic terms. The next step obviously is to uncover the eye. Since you have covered the seemingly fixating eye, the non-fixating eye will either take up the fixation. It has to, because there is no other eye to fixate. So it will take up the fixation, or if it is severely amblyopic, then it will not clearly take up the fixation. You can see whether there is a latent nystagmus or not. And so the next step is to uncover that eye. Once you uncover that eye, either the other eye which had taken up the fixation would hold the fixation. In that particular case, you will call it alternate deviation, alternate ESO, alternate exo, alternate hyper. But it would be alternate because both the eyes are able to take up the fixation. So patient or child is able to alternate. This is completely different from alternate cover test. If you do an alternate cover test, never do that. What happens is in the OPD, we want to do it quickly, and normally in post-graduation, patient comes, we do an alternate cover test. That would always tell you that there is an alternate deviation because you have alternatively covered the eye. So there is no other way of finding out whether there is a unilateral deviation or not, but by doing a cover-uncover test. So the fixing eye may hold the fixation or it may lose the fixation. If it loses the fixation, then it is unilateral deviation. The seemingly fixating eye again takes up the fixation. Sometimes the eye may hold the fixation but may lose it after a blink or a movement. This is alternate deviation with one eye being dominant. What is alternate cover test? Alternate cover test is when none of the eyes are fixing and you want to manifest the latent deviation, which means that there is a phoria. You want to break the fusion, so you don't want at any point of time both the eyes to remain open. So you do an alternate cover test, and then you want to make sure that the latent deviation becomes manifest. So this test will tell us about phoric deviation. Now this is just a small video, but we will move forward. I think there is a okay, video is not working. It's okay. So we move on to the amount of deviation. How do you measure the amount of deviation? You measure amount of deviation by keeping appropriate prisms. And what is the direction in which you keep? If there is esotropia, you will keep it base out. So you will remember it like apex towards the deviation, which means that apex of the prism will be towards the deviation. So if it is ESO, the apex will be on the nasal side. But when you write it in your book or in your case paper, you will write on the basis of base. So if apex is towards the deviation, if apex is nasal, the base will be towards the temporal side. Out means towards the ear and in means towards the center part of the body. So it is base in, base out. So for ESO, you will use a base out prism, and it is recorded in prism diopters. Now this is just a small test to show a Krimsky test in a partially accommodative case. This is a child. The mother is holding his ear. You can see that there is a left esotropia. Once you give him glasses, we have covered his right eye, the seemingly fixating eye. The left eye takes up the fixation. The moment we leave it, the left eye goes back, which means that it is a unilateral deviation, left eye esotropia. The child had plus 6.5 glasses, and so we give the glasses, again do the test. The left eye, you can see that he is not able to see clearly and is sort of searching. Left eye has poor vision, and so cover test also tells you that left eye is not able to hold fixation. Left eye is indeed amblyopic. Then you move on to put prisms. Here you would use apex towards the deviation. This is modified Krimsky's test, where we are putting apex towards the deviation prisms in front of the fixing eye, and we try to see that the light should try to come that. So that would be apex towards the deviation. So next we will see ocular movements. Now ocular movements can be broadly divided into ductions, versions and vergences. So ductions, you can see that this is where you can see the ductions. You can see that the patient is able to move. You can see that there is a small infraoblique overreaction here. When you cover one of the eyes, it is duction. When you see with both eyes together, it is vergence. And when you do a disconjugate movement, it is convergence or divergence. We will just move. Okay, this was a small device which we made to measure ductions, and this is to measure ocular movements. And this is the normative data for abduction, adduction, elevation, and depression. So this is just to tell you about measuring ductions. Okay. Now we move on to the second part of strabismus evaluation, and that is evaluation of the sensory status. Now, what is binocular single vision? It has been grossly divided into three parts. This was divided way back in 50s by Worth. Claude Worth was the guy who divided this. Now, you know, this a very important point here we have to understand is that these divisions are made by us for our understanding, for our reproduction, that we can reproduce the same thing, like simultaneous macular perception. If I am seeing on a synoptophore, somebody else should be able to reproduce the same thing. Nature doesn't work like that. There is a possibility that on one test you will see fusion, and if there is another test which is more dissociative, you may see that the patient is not able to fuse. However, the prerequisite for these things are that images should be falling on corresponding retina, and they should be almost of the same size and shape. Only then they can overlap. Simultaneous macular perception is between fovea and the parafoveal area. Fusion is sensory and motor. So motor is when the ocular movement takes place to fuse an object. Otherwise, you will see those things as double, or you will have confusion. And stereoacuity is when the image is still in the Panam's area, but not really on the same horopter. So the difference between fusion and stereoacuity is that in fusion, corresponding retinal elements are stimulated and motor system is required. Here you don't need a motor system, and it is a three-dimensional thing. Fusion, it will function equally well for all fixation distances, and fusion can occur without stereoacuity. But without fusion, you may not have stereoacuity. And stereopsis occurs only in horizontal disparity because horopters are horizontal. You cannot have vertical stereoacuity because both the eyes are horizontally separated. They are not vertically separated. So a trick question is whether vertical stereopsis is there. You cannot have it because the image will still be in the same horopter if it is a vertical separation. This is what I was saying. When you have an image on fovea and on a point which is not on fovea, you may either have confusion or diplopia. And to adapt to that, you have motor fusion to try to bring it back to the center. Then there are So then another question normally is about what is suppression. Now suppression is active central inhibition to avoid confusing images which are originating from the retina of the deviated eye. Because if you are seeing two images, one of the images has to be either suppressed or removed so that you don't have double vision. This can occur only when the visual system is still immature. And you may have another adaptation, which is abnormal retinal correspondence, which is of two types, harmonious. Yeah. So these are some of the tests to see, to look for these sensory status. Red glass filter test. Here, basically, we are dissociating the two eyes with the help of red filter. Worth dot test mainly tells us whether the person is able to see binocularly or not. So it will basically give you an idea whether binocular vision grossly is present or not. The right eye will have red glass, the left eye will have green glass, and the right eye will see 2 dots, left eye will see 3 dots. And this is how you will have a Worth dot test. And no, I don't think we have much time for that video. And then you have other tests like Bagolini's glass, a wonderful test. This is the normal response, and these are some of the tests for stereoacuity. I think just those stereoacuity tests you should see. This is a tetanus fly test, TNO test, and Lang's test, Frisbee test, and this is a gross two pencil test, another wonderful test which you should do for stereo acuity. So thank you so much.